Welcome to the April 2018 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 4 scientific articles published in the April issues of the journal, as well as commentaries by Dr. James A. Shaw on the article entitled Risk Reduction Compared with Access to Care, Quantifying the Trade-off of Enforcing a Body Mass Index Eligibility Criterion for Joint Replacement, and Dr. Nitin B. Jain on the article entitled Effects of a Single Intra-Articular Injection of a Microsphere Formulation of Triamcinolone Acetonide on Knee Osteoarthritis Pain, a double-blinded, randomized, placebo-controlled, multinational study. Be sure to check out this month's Current Concepts Review article, Controversies in the Management of Central Cord Syndrome, The State of the Art by Peter Wagner and colleagues. The authors note that traumatic central cord syndrome is an incomplete spinal cord injury characterized primarily by disproportionate motor and sensory loss in the upper extremities compared with the lower extremities. Initial management of central cord syndrome includes immobilization in a rigid cervical orthosis, maintaining mean arterial pressure, and performing serial neurologic examinations. Central cord syndrome is generally treated surgically, but the timing and surgical approach depend on injury characteristics, including the injury pattern, neurologic examination, and its evolution and patient comorbidities. The authors review the clinical presentation, imaging characteristics, and initial management of patients with traumatic CCS, and they focus on 2 important controversies: surgical indications and the timing of surgery. In this issue, JBJS.org presents a new image quiz. A 52-year-old man with a history of stiffness and pain in the shoulder. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Risk Reduction Compared with Access to Care, Quantifying the Trade-off of Enforcing a Body Mass Index Eligibility Criterion for Joint Replacement, by Dr. Nicholas J. Giordi and Associates. Investigation performed at the VA Palo Alto Healthcare System, Palo Alto, California. Morbidly obese patients with severe osteoarthritis benefit from successful total joint arthroplasty. However, morbid obesity increases the risk of complications. Because of this, some surgeons enforce a body mass index (BMI) eligibility criterion above which total joint arthroplasty is denied. In this study, the authors investigate the trade-off between avoiding complications and restricting access to care when enforcing BMI-based eligibility criteria for total joint arthroplasty. In this retrospective cohort study, the Veterans Health Administration (VHA), Corporate Data Warehouse (CDW), and Veterans Affairs Surgical Quality Improvement Program (VASQIP) databases were reviewed for patients undergoing total joint arthroplasty from October 2011 through September 2014. The authors determined if various BMI eligibility criteria had been enforced over that period of time, how many short-term complications would have been avoided, how many complication-free surgical procedures would have been denied, and the positive predictive value of BMI eligibility criteria as tests for major complications. To provide a frame of reference, the authors also determined what would have happened if eligibility for total joint arthroplasty were arbitrarily determined by flipping a coin. In this study, 27,671 total joint arthroplasties were reviewed. With a BMI criterion of greater than or equal to 40 kilograms per meter squared, 1,148 patients would have been denied a surgical procedure free of major complications, and 83 patients would have avoided a major complication. The positive predictive value of a complication using a BMI of greater than or equal to 40 kilograms per meter squared as a test for major complications was 6.74%. The positive predictive value of a complication using a BMI criterion of 30 kilograms per meter squared was 5.33%. Flipping a coin had a positive predictive value of 5.05%. Conclusions. A 30 kilograms per meter squared criterion for total joint arthroplasty eligibility is marginally better than flipping a coin and should not determine surgical eligibility. With a BMI criterion of greater than or equal to 40 kilograms per meter squared, the number of patients denied a complication-free surgical procedure is about 14 times larger than those spared a complication. Although the acceptable balance between avoiding complications and providing access to care can be debated, such a quantitative assessment helps to inform decisions regarding the advisability of enforcing a BMI criterion for total joint arthroplasty. Next, you'll hear a commentary by Dr. James A. Shaw on the article entitled Risk Reduction Compared with Access to Care, quantifying the trade-off of enforcing a body mass index eligibility criterion for joint replacement.
This is Dr. James A. Shaw providing commentary for the April 2018 JBJS podcast. I will be commenting on the article entitled Risk Reduction Compared with Access to Care, quantifying the trade-off of enforcing a body mass index eligibility criteria for joint replacement. The title of my commentary is Surgical Decision Making, the province of the patient or the surgeon. Dr. Giori et al. Have written an interesting, informative, and provocative article, one sure to engender heated discussion for years to come. The authors acknowledge and thoroughly reference the fact that morbid obesity increases the risks of serious complications following total joint arthroplasty. However, with quoted references stating that 37% of the population in the United States is considered obese, and 7.7% is considered morbidly obese, and with obesity having a documented causal relationship to osteoarthritis, they contend, with rigorous analysis, that many patients would be denied the life-changing benefits of total joint arthroplasty if arbitrary body mass index criteria are used as a decision-making criteria defining eligibility for total joint arthroplasty. The author's analysis documents that avoidance of complications using a BMI of 30 kilograms per meter square as a cutoff criteria for surgical procedure is no better than a coin flip. If a BMI of 40 kilograms per meter squared is used, the number of patients denied beneficial care is 14 times larger than those spared a complication. That being the case, in the original draft of the article, the authors implied that patients should have the freedom of surgical choice independent of the surgeon's concerns or the potential costs to society of 1 in 14 patients in this group having a serious complication. Both clinical manuscript reviewers countered that surgeons have rights as well. Bearing the emotional, time-consuming, and financial burden of a serious complication following total joint arthroplasty is a factor that only a surgeon who has had a patient with serious postoperative complication can appreciate. To quote a sage comment made by Dr. Bob Booth many years ago, quote, "There are 2 horrible complications following total joint arthroplasty. One is death, and the other is deep infection. Of the 2, infection is probably the worst, as the patient wishes he was dead, but so does the surgeon," end quote. In response to the reviewer's critiques, the authors acknowledged the surgeon's rightful role in the decision-making process in the published version of the article. According to the authors, quote, "Surgeons who perform operations on morbidly obese patients also assume responsibility and risk. A decision to operate is a commitment to care for complications. Complications are emotionally draining, require additional time and resources, and can be financially harmful to a surgeon's practice," end quote. In addition, the authors state that they believe that, quote, "it is unreasonable to interfere with the patient and physician relationship by administratively setting rigid surgical eligibility standards for joint replacement, as they can have broad and poorly understood consequences," end quote. All arthroplasty surgeons must deal with the pall of surgical complications on a daily basis. A major distinction from other surgical procedures is that total joint arthroplasty engenders significant risks and is, at the same time, a semi-elective operation, complicating the decision-making process. Every patient with a good result is delighted. Those few with serious complications wish they had never undergone the operation. So surgeons must ask themselves how many patients they are willing to cause harm on a statistical basis to benefit the remainder. A serious complication in 1 of 14 in the 40 kilogram per meter squared BMI group strikes me as an unacceptable risk-to-benefit ratio. Obviously, others may disagree, with no right or wrong opinion. Many patients will state that they cannot live with a hip or knee in its current arthritic state and would rather die and or risk infection or other complications than continue life in its present state of pain and disability. The problem with that declaration is that most patients and family members, in my experience, change their mind when faced with death or major complication. Anger, depression, and or incrimination against a surgeon frequently follows a major complication. The complexity of the surgical decision-making process remains a conundrum with good arguments that both the patient and the surgeon should hold preemptive responsibility. This article does not resolve the debate, but provides for informed discussion regarding the process of shared decision-making.
Next, you'll hear the second abstract of 4 that are being presented in this podcast. This abstract is from the article entitled The Effect of an ACL Reconstruction in Controlling Rotational Knee Stability in Knees with Intact and Physiologic Laxity of Secondary Restraints as defined by Tibiofemoral Compartment Translations and Graft Forces by Dr. Frank R. Noyes and Associates. Investigation performed at the Jewish Hospital, Mercy Health, and the Noyes Knee Institute, Cincinnati, Ohio. The effect of an anterior cruciate ligament ACL reconstruction on restoring normal knee kinematics in unstable knees with physiologic laxity of secondary ligamentous restraints remains unknown. The purpose of this study was to determine the stabilizing function of an ACL reconstruction and the resulting ACL graft forces in knees with severely abnormal anterior subluxation due to associated laxity of secondary restraints. A 6 degree of freedom robotic simulator was used to test 21 cadaveric knees studied as a whole and in subgroups of lax secondary restraints, lax SR, and intact secondary restraints, intact SR, based on abnormal translations and tibial rotations. Native ACL sectioned and ACL reconstructed conditions were tested. An instrumented bone patellar tendon bone BPTB graft measured ACL graft forces. The loading profile involved the Lockman test, anterior tibial loading, internal rotation, and 2 pivot shift simulations. Equivalence between conditions was defined as being within 2 millimeters for compartment translation and within 2 degrees for internal tibial rotation, with p less than 0.05. ACL sectioning increased center translation in the Lockman test by a mean of 10.9 millimeters, which was equivalent to native values after ACL reconstruction in all knees, mean difference 0.0 millimeter, and in subgroups of lax SR, mean difference 0.2 millimeter, and intact SR, mean difference minus 0.2 millimeter. ACL sectioning in the pivot shift 5 Newton meters test increased lateral compartment translation to non-native equivalent levels, which were restored to native equivalent values after ACL reconstruction in all knees, mean difference 0.9 millimeter, in the intact SR subgroup, mean difference 1.1 millimeter, and to nearly native equivalents in the lax SR subgroup, mean difference 0.6 millimeter. The highest ACL graft force reached a mean of 109.9 newtons in the pivot shift 5 Newton meters test. Conclusions. The ACL reconstruction restored native kinematics and native rotational stability in all knees, including knees having laxity of secondary ligamentous restraints and clinically equivalent grade 3 pivot shift subluxation, and did so at ACL graft forces that were not excessive. Next, you'll hear the third abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Effects of a Single Intra-Articular Injection of a Microsphere Formulation of Triamcinolone Acetonide on Knee Osteoarthritis Pain, a double-blinded, randomized, placebo-controlled multinational study by Dr. Philip G. Conahan and Associates. Intra-articular corticosteroids relieve osteoarthritis pain, but rapid systemic absorption limits efficacy. FX006, a novel microsphere-based extended-release triamcinolone acetonide TA formulation, prolongs TA joint residence and reduces systemic exposure compared with standard TA crystalline suspension, TACS. The authors assessed symptomatic benefits and safety of FX006 compared with saline solution placebo and TACS. In this Phase 3 multi-center double-blinded 24-week study, adults 40 years of age or older with knee osteoarthritis and average daily pain ADP intensity scores of 5 or greater and 9 or less on a 0 to 10 numeric rating scale were centrally randomized to a single intra-articular injection of FX006, 32 milligrams, saline solution placebo, or TACS, 40 milligrams. The primary endpoint was change from baseline to week 12 in weekly mean ADP intensity scores for FX006 compared with saline solution placebo. Secondary endpoints were area under effect AUE curves of the change in weekly mean ADP intensity scores from baseline to week 12 for FX006 compared with saline solution placebo. AUE curves of the change in weekly mean ADP intensity scores from baseline to week 12 for FX006 compared with TACS. Change in weekly mean ADP intensity scores from baseline to week 12 for FX006 compared with TACS, and AUE curves of the change in weekly mean ADP intensity scores from baseline to week 24 for FX006 compared with saline solution placebo. Exploratory endpoints included week 12 changes in Western Ontario and McMaster University's Osteoarthritis Index, WOMAC, and knee injury and osteoarthritis outcome score quality of life, KOOS-QOL subscale scores for FX006 compared with saline solution placebo and TACS. Adverse events were elicited at each inpatient visit. The primary endpoint was met. Among 484 treated patients, FX006 provided significant week 12 improvement in ADP intensity compared with that observed for saline solution placebo, indicating approximately 50% improvement. FX006 afforded improvements over saline solution placebo for all secondary and exploratory endpoints. Improvements in osteoarthritis pain were not significant for FX006 compared with TACS, using the ADP-based secondary measures. Exploratory analyses of WOMAC A, B, and C and KOOS-QOL subscales favored FX006. Adverse events were generally mild, occurring at similar frequencies across treatments. Conclusions. FX006 provided significant clinically meaningful pain reduction compared with saline solution placebo at week 12, primary endpoint. Next, you'll hear a commentary by Dr. Nitin B. Jain on the article entitled Effects of a Single Intra-Articular Injection of a Microsphere Formulation of Triamcinolone Acetonide on Knee Osteoarthritis Pain, a double-blinded randomized placebo-controlled multinational study.
This is Dr. Nitin B. Jain providing commentary for the April 2018 JBJS podcast. I will be providing commentary on the article entitled Effects of a Single Intra-Articular Injection of a Microsphere Formulation Acetonide on Knee Osteoarthritis Pain, a double-blinded, randomized, placebo-controlled multinational study. The title of my commentary is, Do These Crystals Really Sparkle? Knee osteoarthritis is a public health issue of gigantic proportions, with the burden likely to increase in the coming decades. Pain and functional disability from knee osteoarthritis are major patient concerns. Given the lack of a disease-modifying agent for knee osteoarthritis, therapies that can reduce pain and improve function are our best alternatives. In addition to analgesics and strengthening exercises, intra-articular corticosteroids are the mainstay of treatment in clinical practice. There is debate about the efficacy of intra-articular corticosteroids, their longevity in providing symptom relief, and potential adverse effects on cartilage thickness. Thus, the alternative of an extended-release corticosteroid formulation is quite attractive. Conahan and colleagues performed a well-designed and robust multi-center clinical trial. They report the efficacy of FX006, a microsphere-based extended-release formulation of triamcinolone acetonide as compared with placebo saline solution. The results convincingly demonstrate the superiority of FX006 over placebo for pain relief and functional outcomes at 12 weeks, as assessed by change in weekly mean average daily pain, or ADP, intensity, the primary outcome measure, and the Western Ontario and McMaster University's Osteoarthritis Index, or WOMAC, and knee injury and osteoarthritis outcome score, or KOOS. The results were not as impressive for the comparison of FX006 and standard triamcinolone acetonide crystalline suspension. the authors did not identify a significant difference between FX06 and Triamcinolone for the primary outcome. However, some of the exploratory endpoints, which were changes in WOMAC and KOOS, were suggestive of a significant difference. What are the clinical implications of this study? At this point, the study provides evidence of the efficacy of FX006 compared with saline solution placebo. Hence, implications to clinicians who have concerns that Triamcinolone is not effective in knee osteoarthritis. The likely increased cost of FX006 over Triamcinolone may not sufficiently justify its use in clinical practice. The big question is whether FX006 is superior to Triamcinolone, which is arguably the standard of care for intra-articular corticosteroid therapy. A follow-up trial with a primary head-to-head comparison of FX006 and Triamcinolone could potentially make a major impact on clinical practice. Given the infrastructure available to the authors, they are encouraged to perform this trial. In the era of limited federal funding of research, this clinical trial is an example of an industry and academic partnership that can produce high-level, patient-oriented research. Certainly, industry has an interest in evaluating its products, and academic physicians are in a strong position to deliver on such projects. With safeguards in place to avoid compromising research ethics, such partnerships may lead to important scientific advancements.
Next, you'll hear the last abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Association Between Distal Radial Fracture Malunion and Patient-Reported Activity Limitations, a long-term follow-up by Dr. Muhammad Ali and Associates. Investigation performed at the Department of Orthopedics, Kristianstad and Hässleholm Hospitals, Hässleholm, Sweden. The long-term effect of distal radial fracture malunion on activity limitations is unknown. Between 2001 and 2002, the authors conducted a prospective cohort study of all patients with distal radial fracture treated with casting or percutaneous fixation in northeast Scania in Sweden. In that original study, the patients completed the Disabilities of the Arm, Shoulder, and Hand DASH questionnaire at baseline and at 2 years. The authors performed a long-term follow-up study of patients who were 18 to 65 years of age at the time of the fracture to investigate the association between fracture malunion and activity limitations. In this long-term follow-up, patients who had participated in the original study completed the DASH questionnaire and a visual analog scale VAS for pain and for satisfaction, scored 0 to 100, and underwent radiographic and physical examinations at 12 to 14 years after the fracture. The authors define malunion as dorsal angulation of 10 degrees or greater, ulnar variance of 3 millimeters or greater, and or radial inclination of 15 degrees or less. They also assess the presence of radiocarpal osteoarthritis and ulnar styloid nonunion. The primary outcome was the change in DASH score from baseline. Secondary outcomes were DASH, pain, and satisfaction scores, wrist range of motion, and grip strength at the time of the follow-up. Of 85 eligible patients, 63, 74%, responded to the questionnaires and underwent examinations. Malunion was found in 25 patients, osteoarthritis was found in 38 patients, and styloid nonunion was found in 9 patients. Compared with patients without malunion, those with malunion had significantly worse DASH scores from baseline to 12 to 14 years. The adjusted mean difference was 11 points. Similarly, follow-up scores were significantly worse among patients with malunion. The adjusted mean difference was 14 points for DASH scores, 10 points for VAS pain scores, and 26 points for VAS satisfaction scores. No differences were found in range of motion or grip strength. Osteoarthritis, mostly mild, and styloid nonunion had no significant association with DASH scores, VAS pain or satisfaction scores, or grip strength. Conclusions. Patients who sustain a distal radial fracture at the age of 18 to 65 years and develop malunion are more likely to have worse long-term outcomes, including activity limitations and pain. Thank you for listening to this JBJS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.